Allie, have you ever considered just not going to the doctor or being ashamed to go there or maybe ashamed to talk about weight loss medications or gone into a room and assessed, will I fit in the chairs in this room? This sort of thing ever?
Actually, no, Shauna, and I'm so glad we have our guest today who is an expert in the field of obesity and people living with obesity, studying that and helping us to understand what that life is like. We have Dr. Robyn Pashby on the show today, who is a licensed clinical health psychologist and the founder of Health Psychology Partners in Washington, D.C. And she's going to help us understand what it's like to live with obesity.
And before we dive in, let's give a shout out to our Girls Talk Healthy Aging listener, Miss Autumn Lucas. Thanks so much. Let's dive in.
Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Allie Kerr.
And I'm Shauna Kaminsky. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey.
Dr. Pashby, can you please clear something up for me about how to speak about obesity? Because as a trainer, we used to do these tests. We would do the body fat things on clients, and then we would like place them in a category back in the day, and it would be like obesity, morbid obesity, and these things, thankfully, I think some of that's changed. Can you tell us some of the things that have changed with that and how we speak about it?
Thank you for that question. So let me just say that was my generation also. So I now look back at some of the things that I wrote in textbooks and other places with a little cringe. So what we've really moved toward as a field, and let me be clear, when I say a field, I mean obesity medicine, is person first language. And I actually worked with the American Psychological Association on language and sort of safe language and really acknowledging that the words that we use affect people, right? Whether we're talking about a person with a disability or versus a disabled person, for example, right? And so the same is true in people living with obesity. So we really try to do person first rather than condition first. And one of the examples that's sometimes used is you wouldn't say, well, this cancerous patient is coming to see me today, any more than you would say this obese patient is coming to see me today. You would say a person with cancer, a person with obesity, because that really reflects the fact that obesity is a complex chronic disease. The Obesity Action Coalition, of which I'm a member of the National Board of Directors, has really pioneered that work, and I'm really proud to be a part of them. They're a patient advocacy organization. But I will acknowledge, eyes wide open, that even when we use language like person with obesity, that there is a whole group of people out in the world who don't want that language either. And I think it's not my choice to say what someone should prefer or should not prefer. It's people's choice, right? And so I think when you're working with someone, what I hope is that you listen to the words they use and even ask. So in my clinical practice, if I'm working with someone new, I might ask, what's the language you prefer to use around weight? Because what's used in the medical context, which we're moving more toward person with obesity, could be very different than the clinical context, could be very different for someone who practices a health at every size approach, could be different for someone who lives in the fat activism or fat acceptance community, where the word fat is really reclaimed as an empowered term. So I just want to highlight that this is a really complex issue that I spend a lot of time thinking about and talking about. And for the purposes of our discussion, working in the areas of healthcare, I think it's okay to say a person living with obesity, but I just want to say that I know that that still isn't great for some people's preferences.
Yeah, and when we were actually emailing back and forth about the podcast, you were kind enough to correct me when I was writing some of the potential things that I wanted to talk about. So I hope that you'll do that during this podcast, because it's going to take some practice, because there's things that we just say, I know me, that I just say and don't even realize it. So thank you for educating us about that.
I am so grateful that so every time I have to correct someone or or say something, I'm just so glad that people are open-minded enough to hear a different perspective, right? I don't expect people to get it right all the time. It's the growth mindset, right? It's the idea that, oh, this is changing and I can change too.
Yeah, and it is an improvement. And even though it's not perfect,
Right.
it's an improvement, acknowledging that there is a person with a health issue.
Yes.
Let's acknowledge the person before the health issue.
Yes, exactly.
And let's dive into the whole topic of the field of obesity, which you have many years studying and being involved. You're in Washington, D.C. That's where your practice is.
Yes.
So you're seeing patients with obesity, living with obesity, and you're speaking. So tell us what you're seeing that is changing in this rapidly changing. I feel like it's rapidly changing. You tell us.
Oh my goodness. So I think I first started my work in the area of obesity and weight regulation and eating behavior all mixed together back in 2000, where I first started dipping my toe into that area and really finding, oh, I like this. This feels right to me. So I have a personal lived experience with obesity. I have a family experience with obesity. We've gone on every diet. We've done every plan that, the cabbage soup and you name it. And so I came to this with, of course, some personal interest, but also I was just sort of fortunate enough over time to keep meeting new people who I found really intriguing in terms of the way they are asking research questions about weight and eating behavior. And over the last, 20 plus years, I've seen a couple things. One is I've seen this shift in person first language that we just talked about. Two, I've seen patients and people living with weight struggles really working on reclaiming a sense of self-worth, independent of their body weight and shape. And I am all for that. I'm sure you two are as well, right? The idea that your body weight dictates your self-worth is way antiquated, right? Outdated, old school. We got to get rid of that. And I started to see that. But that said, there remains such deep stigma in society in general, and certainly internalized stigma that people living with weight struggles have felt much of their lives. Of course, the GLPs are here. I will say, because I've been in clinical practice for a long time now, the GLPs have been around for a lot longer than the media likes us to believe. They were used to treat diabetes, but there were other older forms of GLPs that have been available and used in weight management contexts for many, many years. They just didn't have quite the robust impact on body weight that the Ozempics of the world did. And so then suddenly the media caught on and thought, oh, this is something really important that we should pay attention to. And therefore, more patients are using them than ever before, of course.
Is it the fact that the media has kind of gotten a hold of the whole GLP-1 concept that it just blew up? Because for many people, it just is a new arrival on the scene. And that has caused some trepidation that, oh, these drugs are brand new. What are they going to do? But people don't realize that they've been around for probably 30 years.
Yes. And certainly, I think Ozempic for the treatment of diabetes has been FDA approved for a decade or more. So these are, now well-established meds. So I think the media certainly, but also when you get FDA approval, right, for a medication specifically for weight rather than for diabetes, I think that's the game changer in this equation. We've had many more meds that many of my patients have tried over the years, and some of them have been quite successful. Why that? And I want to be careful about two things. The word success is loaded from a weight loss and weight management perspective. But also, I think it's really important to highlight that there are these older generation medications available because access to the GLPs is a real issue. They are expensive, they are not available in every place, and they are not accessible to individual people for a variety of reasons, either choice or finances or family values or fears of injections. There's all kinds of reasons that people don't use meds like the GLPs. So I want to remind people that that's not the only thing available. I think we sort of are now in this place where there's so much discussion around the GLPs that we fall into this either that or nothing bucket. And I hate for people to live like thinking that, because there are other options out there, medical treatment options. But the success thing is really tricky, because I challenge myself and you two and every client that I work with, every person that listens to me speak, to really think about what we mean when we mean success. Does success just mean losing weight? Does success mean dropping a BMI category? Spoiler alert, no. Does success mean, I don't know, feeling better, having lower cholesterol, having lower blood pressure? All of those factors are very individual. And I think we have to appreciate that for every person, they're so unique.
We're going to interrupt this interview for just a second because we've got something we want to make sure that you know.
If you're struggling with your health, with your fitness, if you don't know where to start, or you know what to do and you're not doing it, we're here for you.
And all you need to do to get our help is to reach out to Shauna and I at our email, sapodcast23@gmail.com. And we're happy to help, and we will be in touch. Now back to the show.
You know, you're mentioning that GLP-1s are available, but other weight loss drugs are available. But there's still the stigma, no matter what drug a person may consider using, it's still, I'm cheating, or so-and-so is cheating because they're using these drugs, which is ridiculous.
Right. It's this whole notion that it's the easy way out, right? That if people just fill in the blank, had more willpower, had more self-control, weren't so lazy, ate less and moved more, all those things, right? And by the way, I have clients who use medications and still think those things, right? I wouldn't need this if I ate less and moved more, if I didn't. I mean, the mean self-talk people have around this, right? And so just because you opt to use one doesn't mean that all that other way of thinking about it goes away.
Right.
Yeah, the stigma is really sticky.
Yeah, and you deal with the mental side because you're a medical psychologist, clinical psychologist. And so weight loss, can we talk about the fact that it's not easy, even if you're supposedly successful at losing weight, maybe losing large amounts of weight. There are pros and cons. There are good things, wins, and then there are challenges, relationships. I'm sure you can tell us some of those, marriages, some of the challenges that come with a major change like that.
Yes.
Can we talk about that?
Yes. Oh my gosh. Yes. So I am a psychologist, and I work obviously on the mental health side of things, but you know that encompasses relationships and behaviors and workplace experiences. All of that, right, is sort of what comes and sits in my office. And so first and foremost, I want to be clear that when people who are trying to manage their weight and experience weight loss that helps their health, most of the time, that's the goal, right? That it is okay for people to think, boy, I would like more mobility, or I'm sick of having low back pain and knee pain and high cholesterol and high blood pressure and a high A1C. I want to manage my weight because I want my health to be, have more longevity, or I want to move with my family or my grandkids or whatever. So I don't want it to come across like I'm saying weight management is not important. For some people, it really is. But I think when we talk about weight loss, it has really big connotations in terms of how people feel about themselves, because so often, do you lose weight or not is actually not the question. What the question people are thinking about is, am I good or bad? Am I a success or a failure? Am I smart or dumb, right? It's like it becomes this really binary thing. And I think that is so dangerous to health and mental health in particular. So what I hope people focus on is their health and their mental health, period, right? we know where we live in this society, that's not all people think about, right? So there are some other benefits, and I don't want to minimize these either. People feel more, can feel more self-empowered, have more self-esteem, have improved body image, and therefore that can reflect in relationships. Now, of course, the other side of it, so sometimes people lose weight and have new body image concerns related to skin changes or, you know, sudden visibility, quite honestly, right? I mean, suddenly being asked by your boss to go in and give a presentation in front of a room when you weighed 60 extra pounds, the boss had no interest in you doing that. Suddenly that kind of visibility can be really challenging for people. And not for everyone, but I think that we have to acknowledge that there's a very high prevalence of trauma history for people living with severe obesity. There's also trauma of living with obesity in our society, particularly for women who grew up back when we grew up, right, where there was a way to look, and that was the good way, right? And if you didn't fit that picture, you got made fun of, you got teased, you got abused in some cases. So there's a lot of trauma experiences, and sometimes like the invisibility that is an unfortunate side effect of living with high weight in our culture can actually feel safe if you've had a lot of trauma background. And so when you start to shed some of that, the visibility can feel very risky for some people. Again, not all by any means, but I think we have to bring out these sort of the range of experiences for people, because it's not all, puppies and rainbows all the time.
Yeah, a question, if just a curiosity, and I wonder if you see this on the mental health side. Do you see clients that could benefit from GLP-1s that you see in practice, but that's something that they haven't tried, like they haven't tried the medications? And I'm just curious as to why that might be, because I mean, we do see a lot of people have tried them, and a lot of people are using them successfully to get healthier.
Mm-hmm.
But then there's a lot of people that haven't tried, and I'm not saying that everybody should. I'm just curious as to any mental blocks to using the medication that might benefit people.
I appreciate that question. I would say for me, besides the obvious access, cost, all of those very glaring issues, right, which come first, to me, they follow. What quickly follows is fear.
Mm-hmm.
We had like the fen crisis back in the day, right? So people still understandably have that on their minds. We have lack of trust in relationships with their doctors. We have lack of awareness from doctors to suggest these medications. And some doctors who know about them don't want to offend, don't know what to say, don't want to bring it up because they don't, it feels very like landmines. And then we have shame. It's so scary to advocate for yourself and ask a healthcare provider for access to one of these meds when, you've promised them the last 6 years running that you'd lose 20 pounds before your next physical and never have, right? It just feels like, another thing I'm going to ask for. It's the easy way out thing, all that stuff. So that just really runs as a through line.
I think that we sometimes, we think, well, if I've not lived in an obese body, so let me first just put that out there. But just talking to clients that I've worked with, that there's this almost, it wasn't what I thought it was going to be when I lost the weight. Like I thought that it was going to be sunshine and roses and, life was good. But I didn't realize that there were going to be A, these challenges along the way, and B, these new challenges that I haven't experienced before.
Right. Exactly. Yeah. Yes. And I think when you add the GLPs into this equation, right now, as we're recording this today, our most up-to-date data tell us that the average person really only uses these for about a year. Now, that's contrary to what is clinically indicated, which is long-term use, long-term management. I think there's a lot of factors in that. Some people just sort of still have the mentality like, I should be able to do this on my own. So I'll use these as a jump start, which is not what they're used for, nor clinically indicated, nor appropriate, but still people think that. There's side effects, there's cost, there's access, there's all those reasons that people may discontinue use. And so, I mean, most of my clients, when they start to lose weight, what immediately comes up is fear of regain. Because if you've weight cycled, as many people have, regain is what follows weight loss, right? And so I think people, the minute the weight starts to come down, it's almost like it intersects really quickly with a lot of anxiety about, well, what happens when this ends? And I think we have to acknowledge that there's a lot of things we don't know necessarily about what happens long term when people discontinue use. And right now what we see is that, yeah, there's some regain, because this is a chronic disease that can't be treated for 1 year and then discontinue treatment.
One thing I often mention to my clients, who some are and some aren't using these weight loss drugs, is that weight loss should be slow because it enables you to embrace the habits needed to sustain the weight loss. But a challenge, the bonus of the GLP-1 use is there is a faster weight loss trajectory, which does make it hard to really embed those habits. So, how do you help your clients with the habit formation and really embracing the lifestyle skills needed to maintain weight loss? Because that really would make them feel more empowered over time, would be my guess.
Yes. So that's a really interesting question. And we can look at bariatric surgery as a parallel to this, right? What we've learned over time. And here's where I land on that. All of us, every single one of us, whether we live with obesity, whether we live with overweight, or whether we live with underweight, right, could benefit from lifestyle changes. All of us, I mean, I speak for myself, like a perimenopausal woman with a full-time job and a family, I could probably do better with my sleep hygiene. I could probably do better than with my stress management. All of these things, right? And you too probably could feel the same way. It's a constant effort. And I think one of the things I don't like about the sort of conversation around GLPs is that, like, oh, if people just learn to behave better, they will manage their weight long term, right? I don't think that's fair, because so many of my clients are working on their nutrition, are working on their physical activity, are trying to get their sleep, hydrate, stress management, you name it, right? All the things that you are doing, I'm doing. And it's that their body has a genetic predisposition to carry excess adipose tissue. B, they have the fat cells and the sort of biological memory, depending on how long they've lived with excess adipose tissue. So it's not quite as easy. Like, they can be doing all the things and still regain weight. And I think that's the trickiest part. So I try to talk to people like, yeah, let's work on your habits, because every single living human being needs to work on our habits. We're lucky enough to live in a society of abundance. And we're lucky enough to have jobs where many of us sit inside all day, right? I mean, let's just face it, like, we don't have the kind of lifestyle that our ancestors did, right? And so therefore, we have the biology of our ancestors and the environment of the Jetsons, and we expect that to go well, right? And it doesn't always go well.
Yeah. And maybe I misspoke, because I think the way that came out, it sounded like I was saying many people are just sitting still and doing the drive-through. That I do know that is not the case.
Yeah.
But I do agree with you that we can all benefit from looking at habits. And I think people living with obesity have been dealt a difficult hand, and life is not fair, that they might have to be more consistent
Yes.
than somebody else, which we all know that person that just can eat nonstop and have a six-pack.
Yeah.
This is just the way it is.
Right. And so the interesting thing about the GLPs, I'll add, is that I have seen when someone is what we sort of anecdotally call like a super responder, someone that has a real noticeable impact of the meds, it's like there's almost like a gravitation toward different food types, toward eating less, different cravings, a major reduction in cravings, all these things. And by the way, as you probably know, not just for food, but for alcohol, for online shopping, for all sorts of addictive behavior patterns, we're starting to see these things crop up, right? So, really in general, like if people have learned to use food to soothe mood, which most of us have, I think, like it's actually really inconsequential if you don't have the biology that predisposes you to carry excess adipose tissue, right? I mean, a lot of people use food to cope and don't live with obesity. A lot of people living with obesity use food to cope. And so I think I like to just remind people, yeah, there's definitely tools. I mean, I think when you add and layer on the sort of societal stigma and living with the trauma of being disregarded because of your body size, that we know that stigma increases people's desire for eating. It impacts their willingness and safety feelings around movement and physical activity. I tell the story sometimes of a client of mine who just had left the gym, and she worked with a personal trainer a couple of times a week. She'd been going for years at this point, and she was literally walking down the street, kind of near where my office is. And she had just left the gym, and she had like her towel and other stuff in her hands. And someone literally threw a bag of fast food trash out the window at her and said a pejorative term about her size. And then, why don't you go in that gym? She had just left the gym. Now, this person driving down the street did not know that, nor did they care. And that's obviously a very egregious example, but there's lots of examples of feeling not welcome in the gym space, right? And so there are, I think, other complicating factors when you live with obesity that make weight management harder, basically.
What are some more of the stigmas, maybe from years ago versus now? Whether it be about like going to the gym or going to the doctor, what are some of the stigmas and how have those things changed? And as far as just how we think about that number on the scale.
Well, look, I mean, one of the beautiful things I think about 2025, so we have more role models in sports and in fashion and other places that are women living in a variety of body sizes. And so I do think that there's a growing awareness that women come in all, and men too, for that matter, right, come in all shapes and sizes. And I mean, certainly when I was growing up, that was not the case. And so I'm hopeful. I have a almost 10-year-old daughter, and I try really hard. I'm very conscious of like the types of dolls that I have bought her whole life, a range of sizes and a range of colors and a range of fashion and all of these things, because I think we have more access to those things. And so that's a great thing to teach people from a young age. But the stigmas around willpower and like self-determination persist. And I think in part because that's the principles, or some of those are the principles on which America was really founded, right? It's like the American dream. You work hard and you succeed. And I think that has gone beyond just like, coming over with $5 in your pocket and becoming a millionaire, but also if you just work hard enough, you'll be thin, and thin is the idealized state. So there's a lot of complexity in that question.
Yeah. And it is unfortunate that the thin is the idealized state, because thin is not necessarily healthy, and trying to get the message that somebody carrying a little bit more body weight could actually be significantly more healthy than someone that is the idealized shape.
Yes. Well, and part of that, if we're honest, a lot of the BMI categories and other things have a fairly race focused background. And, there are data that tell us that, for example, Black women can hold more body weight and have health outcomes that are fine than, for example, Asian Asian women or men who have sort of a lower body weight range where they start seeing health outcome changes in the negative direction. So we have, there are very, I don't know, like sort of mixed data depending on the person in front of you. And I think we have to be honest that some of the thin ideal also has origins in, in ideals in other ways too.
Yeah. Dr. Pashby, talk to us about, and because I'm sure you've dealt with this with some of your patients, a little bit more about people that have stopped GLP-1, that have started and then stopped, because I know you said most people are on it for a year. So how has that affected the mental side of things?
Mm-hmm. This is where that whole, like, am I a success or am I a failure comes into play? Because I think people are likely to experience feelings of like another thing that didn't work, right? And instead of thinking that didn't work for me, it's I failed. I couldn't do it. I gave up on it. I'm the problem. And so I do worry about that mentality. And some people cycle off very aware, very consciously, very thoughtfully. And that actually may have a different landing in terms of the mental implications. But I think a lot of people are getting meds online and then managing themselves and then discontinuing on their own. And I hope that people, for example, like listening to this is why I want to have these conversations so that they hear, if that's you, that there are actually amazing healthcare providers out there that can talk to you about older meds, that can talk to you about other options for managing your weight and managing your health that go far beyond the GLPs, that you're not a failure if you've discontinued use and have started to experience regain. So I hope people will reach out to healthcare providers. And I know that that's a slippery slope for some people, but.
And that is the scary part, is that marketing and getting GLP-1s in the hands of many at the cost of decent medical advice.
Yes.
Is scary.
It really is. And I will say, there's not an ounce of me that doesn't understand why people feel safer filling out a form online than going to talk to their physician about a weight loss medication, right? I mean, I just was reading an article that one of my friends was quoted in, and she said, I used to think of a good doctor's appointment as one where I didn't get in the car after the appointment and cry.
Right.
Oh, wow.
Right. And so it can feel safer to have an online form that you fill out and have someone ship the medication to you, right? Because there's so much shame and so much outright stigma and bias and judgment from, unfortunately, many people in the medical community. Now, in fairness, I think some of that is changing. There's lots of, I'm a member of all of these different associations and societies and boards for a reason, because I hope to be preaching this message over and over again. And honestly, the healthcare providers, for the most part, that I've talked to are really open to listening. Again, like we started with, they don't always get it right, but no one expects that, right? We just expect openness and sort of person first attention. But so yeah, the healthcare piece is really complicated. I'm not trying to say just go to your doctor, because that might not be safe, truthfully.
Is there a online opportunity with a medical professional? There is that. I'm in Canada.
Okay.
So that's why I'm asking this question in terms of your experience. There is online opportunities to get medication from a medical professional, whereby you would get better care
Yes. I actually have two friends, both who have really amazing companies that are growing by the second. By the time this podcast airs, they'll grow again in terms of providing virtual obesity medicine care, including access to prescriptions for GLPs, but they're board certified obesity medicine physicians, and they are creating comprehensive medical teams that include registered dietitians and exercise physiologists and hopefully mental health impacts, therapists as well. And those are growing in availability sort of by the minute. So I encourage people to look for options like that, including right now, staying away from compounded medications until we know more about that option.
There's always the issue about compounded meds. And I always like experts to tell us why. We need to hear again and again, why is compounded not the better choice over name brand?
Right. So as someone who once treated my beloved dog with compounded chemotherapy, I will say there's nothing wrong with compounding as a process, right? It's the sourcing of the materials for the GLPs that we do not know. And so I want to be clear that that's based on how things are going at this moment today as we record this. We just don't have our fingers around what actual substances are being used in the compounded GLPs. Maybe they're fine in some cases. Maybe they're not fine in other cases. And that is too big of a risk at this juncture. Now, is there a future for that? Maybe, right? I don't want to sort of say like never, ever, ever, but based on what we have now, I would say it's worth waiting and have your pharmacy order it, go through the steps of waiting, because we just don't know about the long-term safety enough as it stands now.
Because all the name brands are FDA approved, they have testing behind them, whereas compounding, that's not the case.
It's not the case. And here's the confusing thing. Some of my clients who are, by the way, some of the smartest people I know, aren't sure what's compounded and what's not compounded, because we have some very large businesses prescribing compounded meds. And it feels like, okay, most of us know not to go to like the newsstand on the corner and get our GLP, right? But it is kind of confusing if you go to like this trusted name brand place that you've, had interactions with for 30 years, and suddenly they're prescribing something that feels like, well, that's got to be safe, right? So I do think it's really confusing. And I think if people have questions about that, like really understanding, there's some decent literature out there around like what Eli Lilly has, not to name too many names, but what all these two big players have, right? Which is Novo Nordisk and Eli Lilly as of today. There's many more coming in the pipeline, but educating yourself on like, what does compounding mean? Where do I get the actual legitimate, branded, and know that that's just where it stands today. And it could all change. In fact, yes. I think it will change. But
yes.
And what is too much weight loss? With one of the things that I see with clients, that the clients, some of them that are doing the compounding, one of the reasons is because they're not eligible for the prescription based on their weight, their current weight. Mm-hmm. And so they're going the compounded route so that they can get access to the medication. That's just one example. I mean, there's different people in different boats, but that's one of them. And whether they're getting it through their doctor, I mean, I'm thinking if you're getting it through the doctor, obviously you've got someone paying attention, you're checking in, you're going in to see the doctor. But if you're not, are you dealing with any of that on the mental health side where people are losing and then maybe that goes further than it health-wise should?
Yes. So this is, I always think to myself, like, what is the most pressing thing on my mind these days? And certainly access to care and those things are real and important issues, and appreciating the mental health impacts of weight. But I worry so much about people that have struggled with disordered eating and body dysmorphia and body image disturbances, and what access to GLPs through the internet does. Because, I mean, as you probably know, eating disorders, particularly anorexia nervosa, have some of the highest rates of mortality of all mental illness. It is serious business, and people are suffering. And unfortunately, there has been this divide in research and in clinical practice between obesity medicine people and eating disorder people. And the two often bump heads. And what's been really interesting is, just maybe a little shameless plug, I have a book coming out soon on this very topic, because what we're seeing is that there's this kind of stuckness where we're not really used to working at the intersection of disordered eating and obesity. Now, on the patient side, real people, have been living with the combination of high body weight and disordered eating for generations. But I think as fields of science and of treatment, we have kind of specialized, right? Like some of us are obesity people, some of us are eating disorder people. And then we kind of went about our siloed ways. And the GLPs have really started to highlight, we better be cross-talking much more, because there's a lot of people living with various forms of restrictive eating disorders, very disordered body image mentality, that have lived with high weight, but they don't get screened. They don't get asked questions about their eating behavior. And in fact, in the worst case scenario, they can be praised for disordered eating behavior because it's very weight loss friendly, right? So it's not normal to, never eat in public, or to only take, X scoopful of food at every meal and all of these things. It's mostly that falls in the disordered eating camp. But if you put that person living in a larger body and they tell that to their doctor, therapist, trainer, whatever, there's a lot of good for you. You're really working on your weight loss, right? And missing these people. So what I struggle with a lot in my practice is thinking about, how do we educate society, medical providers, trainers, therapists, dietitians, all of those people, about the intersection between high weight and disordered eating, because it is much more common than people give, I think, the time of day to.
Mm-hmm. Well, we would like to give a shameless plug for your book.
Oh, thank you.
Yes. I mean, we can add it to the show notes and tell us a little bit about it, because this is a fascinating topic that we need to learn more about. So
Yes.
share.
So it's coming out. We just sent in our last revisions. I co-wrote it with a few of my amazing colleagues over the years and mentors. And the book is really looking at how there is this stuck place between eating disorders and obesity. And we propose several ideas and really sort of like ways of dealing with the stuckness, which is what mental health people think about, right? How do we help people with the stuckness? And we're really approaching that from a big picture field, like how do we help the two fields come together and start cross-talking and understanding the importance and value in each of those fields to come together. So hopefully, I think it's set for publication this fall. So it's coming. Yeah.
Okay. Well, we may have to circle back and add it to the show notes, and potentially have you as a return guest so that we can dive a little deeper.
It's a really fascinating field. So,
do we have a title yet, or is that going to be coming later?
We do have a title, but I don't think I can share it yet.
Ah!
I saw cover art just today before we came on this podcast. So
that's very exciting.
Yes.
If you had a wish for our listeners today, what would it be?
I think my wish would be that we would understand the impact of stigma and bias on mental and physical health, and that we would understand and appreciate the complexity of obesity and disordered eating in such a way that we ask better questions, demand more from our healthcare providers, and start to ditch some of the shame that people have so that they can get the care that they deserve.
My wish would be that those living with obesity listen to this podcast and get Dr. Pashby's book when it comes out in the fall, and just those that are working in this field too, that we just have a better understanding and listen more and treat people as people.
Mm-hmm.
Yeah, I would have to agree with you, Allie. Even though both you and I, Allie, have been in health and wellness for 30 plus years, as a health and wellness professional, we have a lot to learn. So my wish is that for myself and people like me, that we have a better understanding and compassion so that we can truly help people living with obesity to live a healthier life.
Yes. Thank you both for acknowledging and changing your language just in the course of this podcast. It's so exciting for me, who's been out there sort of tooting this horn for a long time, to see it in action. So I really appreciate your openness.
Thanks for listening. You'll find me, Allie, on Instagram at Allie Kerr Fitness.
And you'll find me, Shauna, on Instagram at Shauna Kaminsky. Feel free to pop us a DM with questions and or feedback. If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience.
Until next time, be healthy and be happy.